This is Dr. Mark Braunstein. I'm the psychiatrist at Open Sky Wilderness, and today we're going to talk about psychiatry in the wilderness and specifically at Open Sky. Please, if you have questions, you can jot them down at any time. It won't interrupt me, and I'll answer them as soon as I can. So, first I'd like to start by talking about the role of the psychiatrist on the treatment team. I'll start with the first bullet point, which is diagnostic clarification. Oftentimes, when young adults and teenagers come into Open Sky, they've been being treated for, say, anxiety or depression. They might be on medications for those things, and for instance, sometimes they might be using a lot of drugs or alcohol. And while they're at Open Sky, and fortunately we can ensure a safe, sober environment, we can see if they still have that anxiety and depression without the substances in. And that has big ramifications in terms of the medication that may be used. Also, sometimes I can help with figuring out a personality disorder versus, say, bipolar disorder, or even helping to elucidate schizophrenia versus substance abuse. Some very interesting cases we have. Also, psychopharmacology, obviously, what that refers to is psychiatric medications. Oftentimes, medications have been started before people come to Open Sky, sometimes right before they came to Open Sky, and they need to be immediately seen to make sure that there's no side effects or it's not having any really inappropriate reactions. Oftentimes, maybe taking away some medications if someone is on, oftentimes nowadays someone can be on 4 or 5 different medications, and kind of really looking at the safety of cocktails that people come in on. Psychopharmacology, we also use a lot in detox. Right now I have a young adult who came in on a significant amount of benzodiazepines, and because I'm out there, this is someone that we can detox from these medications safely instead of having to be in a hospital environment. I'll move on to the next bullet point, which is psychoeducation with students and parents. That's a very important job that I think I have, especially with students. Oftentimes severe mental illness can present itself around 18, give or take. And there might be a lot of non-compliance before someone comes into the program, not trusting of doctors or therapists, and hopefully we can educate them to buy into their illness and the need for treatment and the need for compliance, and to really help them leave just really with a better understanding of themselves and how to advocate for themselves. Really want them to be able to advocate for themselves when they leave. Next bullet point would be treatment plan development, and that's where I work with the clinical team, meet on a weekly basis, talk more than that, and just kind of work with each other. And oftentimes part of wilderness is pushing kids, pushing them past barriers that they haven't been able to get past before, so that they can understand themselves and help themselves to get better. Sometimes we have to push them, and sometimes a therapist might say to me, listen, I'm going to really be pushing him emotionally this week to express some things, and then they might ask me to also help with medications. For instance, I had a kid who was recently on a super maximal dose of couple different antipsychotics. And this had been going on for years, and he hadn't really been getting better. He's still having these hallucinations. And we really had to question, are these actual hallucinations? What's going on here? Because this seemingly normal young man is on a lot of medication for schizophrenia, and it's not helping. And we were able to actually, kind of challenge him on these hallucinations and what are they, and kind of have him to have more insight into them. And to be able to say, oh, they're not that bad, they're getting better, and without really anything else happening with medications. And then I was able to say, you know what? You don't need these. And I'm going to take them away, and your hallucinations are going to get better. And they did. So really working closely with the treatment team would be under that bullet point. I'm going to move on to the next slide. Here. Who sees the psychiatrist? The first bullet point is students coming from the hospital to the detox setting. Obviously, if they're coming to us straight from a hospital because of an overdose, something serious like that, it's a good reason for them to see the psychiatrist when they come to us. Or let's say that a medication was just started a week ago in the hospital, and they're going to need to be followed up on that. Sometimes the hospitals can move very aggressively and quickly with starting medications. Sometimes I'll have, kids go into a hospital before they come here, and they'll go in on no meds, and they'll come out on, let's say, 3 times a normal starting dose of a medication. So obviously, it's very important that they're seen. Coming out of the detox setting, I think we're actually probably doing a little bit more of open sky as a detox setting lately. And that's for obvious reasons. Well, maybe it's not obvious to everyone out there. When people are coming off of, say, benzodiazepines or alcohol, they can have dangerous increases in blood pressure or pulse, per se. So they do need to be watched closely and on medicated for that. But then it can become a safe thing to do. And I think from what I understand in the past, wilderness programs didn't do very much detox. So it's very exciting for me to be able to safely do this in a wilderness setting. The next bullet point, obviously complicated medications. On a couple levels, that's a good reason for them to see me. First of all, they're going into a wilderness setting where they're going to be hiking sometimes upwards of, say, maybe 10 miles a day on the most extreme, or in extremes of the heat or cold. And sometimes when they're on 4 or 5 different medications, it can have cardiovascular complications. It's important to look at this, so obviously nothing medically really happens badly. And then also talking about the complicated medication regimes kids come in on. I understand this. I have an outpatient private practice as well, and I think that one of the great luxuries I have of treating people at Open Sky is that it's a very safe, very structured, and very sober environment. So on an outpatient basis, we can't correct for dysfunctional family dynamics or dysfunctional peer interactions or substance abuse. And sometimes I think that we can rely too heavily on medications because of a lack of a better option, per se. And it's sometimes to keep these kiddos alive, we have to use these complicated cocktails. But what I've been finding at Open Sky over the last 6 or 7 years is that they get better in a wilderness setting. It seems like 90% of the kids are just doing great by the time they leave. And so it seems like an opportunity for me to maybe look at reduction in medications or optimization of these cocktails, because sometimes there isn't, or I should say oftentimes when I've seen them at Open Sky, there isn't a need for 5 different medications if they're going to be in a sober, therapeutic environment. The next bullet point will be recent medication changes. I think I already addressed that a little bit, but obviously if a medication has been changed prior to admission, it needs to be assessed within 2 or 3 weeks to see if it's appropriate or if it's causing side effects or if it should even be continued or lowered. The next bullet point, complex diagnostics. I talked about that a little bit previously in terms of this substance abuse or mood or anxiety or bipolar or psychotic disorders. But also a lot of our patients have, say, personality disorders or personality disorder traits, and just trying to figure out what exactly is going on here, and do they have bipolar disorder or do they have a personality disorder? Or might they have both? Or might this kiddo have autism? I recently saw a 19-year-old guy who had been in and out of hospitals since he was 8 years old and on heavy medications for all that, for most of the last 10 years. And no one had ever diagnosed this kid with autism before. And when, after the first or second time that I and his therapist and the team had met with him, we got together, we're all a little bit afraid to say it because this kiddo had been to all these great programs all over the country, but had never been diagnosed with this, and it was kind of glaring. So yes, complex diagnostics we do get to deal with. So the next bullet point says when it's requested by the therapist or the EC or the parents. EC refers to educational consultants. Educational consultants are the hired advisors / advocates for the children and their families, oftentimes very well educated and very well experienced people, and they might ask for a psychiatric consult or kind of preload the admission saying that this person needs psychiatric care, and it's fantastic when a member of the team can help like that before they even get there. Sometimes the parents will say, listen, Johnny needs to be seen by a psychiatrist. We're choosing your program because you have a psychiatrist and we want him to be seen frequently and followed closely. And then also the therapist will oftentimes request my evaluation, and that's probably most of the time. All right, I'm going to move on to the next slide. Listen, if anyone has any questions, please feel free to ask, okay, anytime. Psychiatric treatment at Open Sky. So right now in the winter, I'm driving out to the field every couple weeks, and in between that, as needed, I can meet with the kids telephonically if they need to be watched really closely, or even on Skype. Sometimes I will see people as soon as they fly in before they go out to the field, in terms of detox, for instance, or psychosis, or just anything kind of heavy needing immediate assistance. But it would probably usually be detox or psychosis. And it's fantastic for me, and I think and the patient, to develop that therapeutic rapport kind of as soon as they get in on their way out. I recently saw a kiddo last week. I had already come from the field. His airplane was a little bit late, which can happen in Durango quite frequently, and they wanted to get him out to the field right away. So we met on a boat ramp by a lake in the middle of nowhere on the way back, and that's where we did our evaluation as the sun was setting. It was beautiful. So I think that addressed the other sessions as needed. The next bullet point would be contact with parents after each visit. What we have going on now is my assistant, currently a paramedic, but also a nurse and at times a naturopath, will contact the parents via email or telephone after each visit, just to kind of keep them abreast. And then if there are additional questions for me, my assistant can help with getting that done so that I can contact the parents as well. I think my favorite way to work with the parents is actually as with the treatment team, so that when the parents will have their weekly meetings with the therapist, I can join that meeting. I think it's great when we're all on the same page. The next point refers to consulting with the home psychiatrist when indicated. Oftentimes, these young adults and kiddos have been seeing people for a while, and it's really helpful for us to be able to get the input from them, and they can help with diagnostic clarification right away. They can help with past medications, kind of letting me know what the next thing they were planning was, things that they were worried about or concerned about. And it's great. I think that oftentimes what I get from the psychiatrist of the kiddos coming into Open Sky, because the kiddos are usually more kind of complicated, is, listen, not really sure what's going on with them. Yes, they have some depression, anxiety, some substance abuse, and medications really aren't working, and we'd love to work with you and see what the wilderness has to offer. So it's kind of open slate somewhat. Also, consulting with the psychiatrist in the program or at home after the patient leaves is a very important thing for me. Often, these kiddos live with us for 8 to 10 weeks. We know them very well and know a lot about them, and really like to be able to pass on my words of wisdom to the next treating physician. Again, so the real wheel doesn't have to be recreated. Then clinical meetings, ongoing consultations with the clinical therapists. What does that mean? So once a week we have a meeting with all the therapists where we go over interesting or difficult cases for supervision. And I get to join in on that meeting, and it's a fantastic educational opportunity for everyone, and also to keep us all on the same page. But besides that meeting, I also speak with the therapist every time I see one of their kiddos. So we work together very closely. I kind of let them know what's going on with medications or therapeutic recommendations, and they can do the same with me. Again, any questions, please feel free to ask. Oh, I have a question. I'm going to go ahead and answer that. Does the doctor-patient privilege apply at Open Sky? And how much information does the parent get about what transpires during an evaluation or a therapy session? That's a really good question. I think there's going to be a difference between how the therapist would answer that question and how I would answer that question. Yes, obviously the doctor-patient privilege does apply at Open Sky and with me and with the therapist, but there are variations in that when you talk about hold on, give me a moment to word this one. When you're doing things for appropriate treatment purposes, sometimes you can. Oh boy, this is a hard question. I'm sorry. Hold on 1 minute. As a doctor, I'm not necessarily going to tell the parents everything the kiddos tell me. That is going to be up to the therapists of what to reveal to the parents more than me. So I'm a little bit more conservative about respecting the doctor-patient privilege. The reason for that is, I'll go into that a bit. Oftentimes before kiddos come to Open Sky, they feel pretty marginalized by their psychiatric treatment, and that they usually feel like the parents have had a pretty major role in guiding their treatment, and they haven't really been heard or been explained to what's going on. And we talked a little bit earlier about psychoeducation, and I talked about having the kiddos be able to advocate for themselves and having a new relationship with their treatment as far as psychiatry goes. So I really honor the doctor-patient relationship that we have a lot, because I think it's going to be a major part of their continuing their wellness in the future. Now, of course, if there is a reason of dangerousness and something that I have a duty to report to the parents, obviously I'll report to the parents and the whole treatment team and any governing bodies that need to know. But for the most part, therapists have this very difficult job. One part which includes, how do you tell the parents or get the kids to tell the parents everything that's been going on without blowing the therapeutic relationship with the kids. So I think that oftentimes part of it is really getting the kids to come around and tell them everything that's been going on. It's a very, very good question, and one that, boy, I don't envy those therapist jobs sometimes. Any other questions, or does anyone want to expand upon that one at all? Psychopharmacology at Open Sky. Medication optimization, and that can refer to reducing medications, raising medications, starting new medications, or tapering or discontinuing medications. I'm going to kind of go through each of those points for you guys to discuss a little bit. When I talk about reduction in medications, what does that mean? And again, I spoke a little earlier about the emphasis placed on medications in an outpatient basis sometimes. And gee whiz, I mean, even kiddos that may not even have ADHD that do have attentional issues, but we're continuing to crank up stimulants or whatnot to address their ADHD. And they come to Open Sky and they're on a super maximal or a maximal dose of Concerta or Vyvanse or Adderall. And then we do this testing, and it doesn't even look like they really have ADHD. Or, boy, if they're eating right and they're exercising and they're not using, look how much better their concentration is. So, for instance, I've got one girl right now that I'm treating that's been on 30 milligrams of medication all along. We've been able to get her down to 15 milligrams of that medication. And her attention is good. And you know what? If in an academic situation, 2 months down the road that she's in, it's not good enough, it can be very easily increased back to where it was. But so you might ask, well, why are we lowering it now if you're going to increase it later? Well, A, we don't know we're going to increase it later. And by decreasing it, if they're insightful and motivated and realizing they're inattentive still at some points or impulsive, they can use some other coping skills they've used. Mindfulness, meditation, for instance. And so they can more easily incorporate techniques of coping skills into their repertoire if they are having some symptoms and aware of them and motivated. And then down the road, they can keep using those coping techniques and not have to rely on the medications as a crutch. Whereas if they kept the medications up all that time, they might not have had the motivation or the need even to work on those coping skills. Let's see, raising medications. Boy, it seems like that doesn't happen a lot at Open Sky. But probably, 1 out of 7 or 5, or I'll say 1 out of 7, give or take, kiddos do get their medications increased while they're at Open Sky. And there's maybe a couple different instances. Let's talk about the one instance where I would increase a medication right off the bat. Let's say that someone comes into a hospital, in from a hospital, they recently had a manic episode, and they're still a little bit psychotic. Well, I'm going to want to optimize that and treat that right away. I don't think about psychosis as being something we want to take time to get better, and that it's not good for the brain or the psyche to have that. So we're going to want that to get better right away. I can increase it. And then, you know what? We can always go down on the medication 5 weeks later when they're stabilized. Another time, and then the other time I might raise it is not right away, but let's say that someone's been on their Prozac 20 milligrams for a long time, and they've now been at Open Sky 4 weeks, 5 weeks, and usually the time where me and the therapist would be seeing some significant improvement that we see maybe in 90% of the kiddos that we're not seeing in them. That would be a time when it's like, okay, let's optimize that Prozac, let's raise it up a little bit, and then we can at least maybe, if we are going to use that agent that's been newly started, I can optimize it while they're there so that by the time they leave, we'll know if it's working or not. And then I can let the next doctor know, and if it wasn't working, what the next plan was, or I can start something before they leave that the next doctor can continue. Starting new medications. So sometimes we have someone, I would, nowadays in modern society and psychiatry, I don't get to see people who haven't been treated by medications much in the past. It seems like that's like the go-to for a lot of people at first. That being said, occasionally I get to see someone who's really been suffering, and they've been doing their work and they've been doing their therapy and they're not using substances, and they've had some depression or anxiety going on for several years. And I can think about a young lady this summer who had some trauma happen several years ago, but had really been suffering from moderate depression for a couple years. And boy, a little bit of Prozac for her, a small dose, really turned things around. And that was really great to see such a large, significant response in this young lady. And then sometimes starting new medications just in terms of, let's say that they've been on different things and the other things aren't working. We're going to try this. Or maybe find something that is a safer cocktail, for instance. Tapering and discontinuing medications. Talked about that a little bit. I think the biggest place to talk about that with is in detox. A lot of young adults coming in on benzodiazepines that have been abusing them as well, or misusing or overusing. And you have to be very careful stopping these medications. And we can do that just kind of however slowly or quickly we need to. Sometimes antidepressants, they come in, they're like, you know what, I want to get off this antidepressant. I've been on my Wellbutrin for 3 years, it's not helping. Okay. Yeah, that's the other thing. It's amazing how often I see people that have been on medications for a long time and are still feeling like crap. And those are places where we can taper some medications, and then see how they are. Again, with sobriety and structure and positive peer interactions and a lot of therapy really helps a lot. I'm sorry, I just got a question. What are benzos? Benzos are benzodiazepines. Tranquilizers, more commonly known as Xanax, Valium, Klonopin, Ativan, and they are useful medications in anxiety, but they're also habit forming and pretty abusable on the street and pretty readily available. And again, people using these medications to numb out their feelings one of the things we like to help people with at Open Sky is to realize that your feelings are okay and your feelings aren't going to kill you. It's the things that you do to yourself to avoid those feelings oftentimes that can kill you. And so helping someone to come off their Valium, for instance, I don't want them to have so much anxiety that they're frozen, but you want them to be aware of it so that they can work on it and express it and not just stuff it in and numb it out. Why wilderness? Talked about this a little bit, just in terms of the sober environment and the support and the structure. As a psychiatrist who was trained with very brief hospitalizations being the rule and not the exception, as some of you might have known if you've ever unfortunately had a loved one or even a child go into a psychiatric institution, you know, the average hospitalization seems to be 3 to 5 days, give or take, and not a lot gets done. Or sometimes things can get done very quickly without lots of forethought or afterthought. Again, having them with us for 8 to 10 weeks while they're sober and they're sleeping with us and they're in the group and they're having these fantastic peer interactions and mirroring situations, get to know them really, really well. And that's just such a valuable experience in today's psychiatric situation. So getting to know them very well. The guides live with them all the time. The guides the guides are the people in the groups who are with the kids 24/7, and I work very closely with them as far as getting symptom report on what's been going on with the kids, and then giving therapeutic recommendations to the guides of what to do with the kiddo this week. For instance, we usually, oftentimes we want kids to be able to advocate for themselves, not advocate, but give themselves praise, to feel better about themselves. And then this week I have this one kiddo, and kind of a little bit opposite, I said to the guides, I just want you guys to tell him all week how great he is doing, because I know now that for him, he's going to internalize us saying that, and he needs that so that he can get to the next step, to be able to do it for himself. And then the 24/7, the monitoring all the time. So if a kiddo wakes up at 1 in the morning with a panic attack, I can work with the guides on how to help them with breathing techniques and mindfulness techniques, or worst case scenario, when to give them a medication to abort that panic attack if necessary. Get to give a lot of, as a group, we get to give a lot of support and therapy to these kids. I mean, we are challenging them, but we're also giving them a lot of care and attention and support while they're here. And that really helps with stabilizing and getting those layers of whatever they put on to numb themselves out or keep who they really are hidden, so that they can really express themselves. And you know, assessment's the last thing on this line, and I think I've already talked about that a lot. And again, I've got to emphasize the sober environment, how wonderful that is. You know, as an outpatient psychiatrist who is trying to treat and assess someone for anxiety when they're drinking every day, it's so hard. And at the same time, if they're suffering, I'm going to help them, and I'm going to treat them, even if they are drinking on an outpatient basis. It's better than having them drink and kill themselves. So hopefully you can drink and get help, and then hopefully get them to look at that and quit. But I can't control for the drinking. And there, when I know that that's maybe having such a big impact on their anxiety, it's very frustrating as a psychiatrist. But at Open Sky, I know they're sober, and that is just so valuable in the assessment and then the ramifications that has as far as treatment goes. Had a very nice young man this summer who had been doing a lot of amphetamines and cocaine and hallucinogens and even PCP, and he's having all these auditory hallucinations. And this poor guy was just, he was suicidal and just totally troubled from these hallucinations, telling him bad things about himself. And then the more drugs he was doing, the more psychotic he was getting, and then the more Risperdal he was getting put on. Risperdal is an antipsychotic, if anyone is knowing. And then, after a few weeks, we were really able to learn that he wasn't actually having organic auditory hallucinations, but it was his own voice telling him these things. And without being able to assess him in a sober environment, and after 3 weeks of sobriety, not just 2 days of sobriety that he might get in the hospital, we were able to figure out, hey, this kid really isn't psychotic. He's just doing way too many drugs and talking to himself. This next slide, I think I talked a little bit about in terms of the long-term treatment plan. But let's go through that again as far as how psychiatry supports a long-term treatment plan. And starting off with jump-starting treatment. I'm going to give the example of detox. For instance, if we weren't able to detox someone from a certain medication, they may not have the symptoms or the motivation or the insight to work on a symptom, so the symptom might never get addressed if they weren't, if that wasn't looked at before. The next part is something that I think is very important. It increases the investment in the future treatment. And you know that kiddos, even young adults sometimes, I said earlier, feel very marginalized by their psychiatric care thus far, and that they feel like they haven't been listened to, or they've been on stimulants all these years and no one has ever taught them what the psychopharmacology behind that is and what receptors it's working on. And I sit down with these kids and I talk about the different medications and what neurotransmitters they're working on, and then they understand it and they're like, wow, man, thanks, doc, no one ever explained that to me before. And I get them to be able to trust in psychiatry and really feel that they're there for themselves and that not just because someone else wants them to be. Let's say that you have a disorder such as bipolar disorder or schizophrenia or even recurrent major depression. What we know now in medicine is that continued treatment over the course of your life is going to be necessary. And if I can get them to have self-awareness and insight into what their symptoms are and how long the symptoms go on before they contact their provider to get a very quick adjustment in their medication that can have giant ramifications on how long this depressive episode is going to go on or how high this manic episode is going to go to. I mean, so I really want them to be involved in the future so that they can call up their doctor and ask and not be BSing about it and not taking medications and just lying to whoever they're sitting in front of. And then the last bullet here refers to the part of the holistic treatment plan. I don't want to get too caught up in the word holistic, but how I think about holistic is when we address all parts of their life, not leaving anything out medically. So I think that oftentimes people can think of holistic as being not involving Western medicine. I think of holistic as the whole shebang, including Western medicine, meditation, yoga, eating right, the whole 9 yards. So it's, and I appreciate that my wellness-oriented treatment team does recognize me as part of a holistic treatment plan and not just I'm a marginalized a medicine doctor. Thank you. Please keep this window browser open. When the presentation is complete, it will take you to a short survey. Now, what other questions do you have? I remember that movie Ferris Bueller's Day Off, and the teacher said, anyone, anyone? Anyone? I'm curious, do any of you have children that are currently at Open Sky? Or any of you looking at this program currently and have any questions? So here's a question. Do you do additional diagnoses in the field? Well, yeah. I think that whenever I see someone, I'm going to be kind of reevaluating the diagnosis that's been given. I don't like to just kind of take someone else's word for it and go along with it. Although obviously if they've come with reports from Mass General Hospital, that's going to go a very long way. But again, yes, we do like to kind of look at that diagnosis. And the other thing is looking at that diagnosis when they're sober and away from really intense family or peer negative dynamics. So yes, definitely work on clarifying diagnoses. Here's a great question. Someone from California asks, if the child is responding to the Open Sky therapies via the psychologist, at what point would you consider reducing the medication? You know, it's variable. Sometimes a reduction can be made immediately when they come in. So that kiddo that I saw by the lake last week, that I had the detox, man, he was on a tremendous amount of medications, and using a lot of drugs, and he was on 2 antidepressants, and for the reasons of how can you really assess and treat his mood or anxiety disorders in the face of this huge substance abuse and the medical ramifications of being on, I don't know, like 9 different medications, we started reducing his antidepressants right off the bat before he even got into the field. Other times it might be, let's say that this person has been here for 5 weeks. They've been doing great the whole time, fantastic. And they've been on this medication for 4 years and it's never worked before. And now they're doing fantastic. I doubt it's because of the medication. It's probably because of what's been going on at Open Sky. So there would be a time to reduce the medication. Any other questions, guys? I'm going to turn this off in a couple minutes. If you guys can please keep your browser window open, that would be awesome. Wait, here's another question. What are the consequences of bringing a teen back to the same environment they were in before they were at Open Sky? How do they get a fresh start? Great question. It's scary to have to send a teenager back to the exact same environment without a lot of changes going on. Oftentimes, we're going to recommend some continued lower grade treatment in a different setting than the environment they were in previously. It's complicated, and it might also have ramifications where I re-add a medication if they're going right back home. If I know that they're going back to that very difficult relationship with their mom that has led them to acting out before, and I know that, say, a little bit of Prozac is going to help with that situation, I might put them back on a medication that they had stopped while they're there. All right, guys, I'm gonna. Oh, here's one. I'm gonna answer one more question. Then I'm gonna sign off. Okay. Let's look at this. Someone is on 20 milligrams of Lexapro, wrapped up from just starting in February 2012, so not even a year on medications yet. I'm wondering if there's going to be another part of a question coming up, because it's not looking like a question. Oh, when I might stop. Let's just look at this one question.